I thank the gentleman from Florida is recognized for 5 minutes.
Thank you very much, Mr. Chairman, and I want to thank our panelists, too. I was fortunate to capture them on the way into the room and had a chance to talk to them earlier, and I'm grateful for that. I appreciate the work that you do. And also, Mr. Neumann, we didn't get a chance to talk, but I welcome you because I understand that you are the one person in the room who's most able to direct the Department of Energy to restart this research, and that's exactly what we would like to see you do. I think you've gathered that from all of us. Congressman Foster suggested that we adopt a standard that has been called, I think Dr. Brink said it as low as reasonably achievable radiation, and I think that is a great model for us to be thinking about. I can tell you as a practicing surgeon that we had a lot of pressure on us to limit radiation exposure, even at the risk of being ignorant of the patient's underlying pathology. So this work is very, very important. My question, and this will be part to Dr. Woloschak on the therapeutic side, but part to Dr. Brink on the diagnostic side. So have we gone overboard in stressing the risks associated with the proper use of diagnostic radiation and therapeutic radiation?
Maybe I can jump in first. I do think that, as you probably experienced in practice, that sometimes patients, there's been quite a lot of press that patients will be exposed to about the potential risk, and sometimes they'll confound potential versus actual, and we'll provide a lot of concern about even getting the necessary imaging that they need. And so very commonly, I'll work hard to try and convince a patient that the benefit of what they would see from undergoing the test would greatly exceed the potential risk that they might face. And I imagine you've faced that in your practice as well.
It was just very, very commonly, and I think there's a sense of alarmism actually among the patients, and they're getting this information from whatever sources that we're over radiating them dangerously. And you're looking at somebody who might have something as simple as a kidney stone, but if they're obstructed and they're infected behind the obstruction, that's a potentially fatal problem. Dr. Woloschak.
Yeah, I think for therapeutic radiation oncology, where you're treating patients with cancer, most often they don't really worry about what the risks are going to be, but where it comes to play is because you're giving a dose all over the body, secondary cancers can come about as a result of the radiation exposure. So after they've been treated, then they're worrying either about, am I going to have a recurrence, or am I going to have a secondary cancer? So it becomes an issue after the fact. I don't think it influences therapy, but certainly the one thing that does influence therapy is how can we make that treatment location be as small as possible to minimize dose to the rest of the body. So we do actually understand quite a bit about low doses because of the scatter of the radiation when we give therapeutic doses.
So that's actually an interesting subject for us. I mean, we obviously worried about bladder and rectal cancers following prostate
Absolutely.
radiation. And can you give us a sense of how common that is,
Yeah, I mean,
rectal and bladder?
Yeah, I'm not really a radiation oncologist. I'm a radiobiologist that teaches radiation oncologists. But the worry is that there is a considerable risk, and in fact, that's what's affected the way that we deliver. So as you know, we're now using seed therapies, for instance, because of worries about radiation damage to the bladder and rectum, mostly from late tissue toxicities that might result. Secondary cancers, there are quite a few studies that have been done looking at what percentage that you'll find in the field and then outside of the field. And there is a pretty considerable risk, not as much to the rectum, but to the other abdominal areas associated with particularly prostate cancer.
And finally, if I could, one of the confusions is when we're talking about radiation, doses of radiation, we think we're measuring it in one type of measurement. And I'd like you to address a little bit either what measure we should be using or how confusing that subject is.
Right, it's a great question. There's so many things that need to be investigated in research on low-dose radiation, and not the least of which is just how to measure it. There's much literature that reports the measurement to the entire body, the organism, the effective dose, and others that really focus on the specific organ that's irradiated. And this alone actually creates a great deal of confusion, and someone just owing to the uncertainty of the best way to measure the dose from any particular study or therapy.
Any follow up on that?
Yeah, and I would agree with that, and also add in that it's a big issue for discussion. I mean, like the National Council on Radiation Protection, we talk about what's the best way to try to calculate dose and figure out dose. It's controversial, and believe me, people, you could fill a room talking about it for days.
So my time has run out, but I hope, Mr. Neumann, what you take away from all this is that we all are cheering for you to go, get on this horse and ride it home. Thanks so much. I yield back, Mr. Chairman.
I thank